Hello everybody. Today we are going to discuss about the hyponatremia. This was also the question which was asked in DRNB critical care exam in October 2023. The hyponatremia developed over a period of less than 48 hours is called acute, usually found in post-operative patient with excessive fluid administration or self-induced water intoxication with severe symptoms. If duration of the hyponatremia is not known or is more than 48 hours, it is called as chronic and is usually asymptomatic with mild symptoms. Degree of hyponatremia may be severe, moderate, or mild. Severe is less than 120. Moderate symptoms if sodium level is between 120 to 129, and the mild hyponatremia when the sodium level is between 130 to 130. The severity of symptoms may be severe, like patient may present with the seizure, coma, respiratory arrest. Mild to moderate, the symptoms will be non-specific, that is headache, lethargy, fatigue, dizziness, nausea, vomiting, confusion, forgetfulness, gait disturbances, and or asymptomatic. Now, the next thing that is important in order to know the etiology of hyponatremia is tonicity. Whether the uh, whether it is hypotonic, isotonic, or hypertonic hyponatremia. So the next concept is pseudo-hyponatremia. Such a pseudo-hyponatremia may be found in presence of hypertriglyceridemia and hyperglycemia that raises the sodium tonicity and pull the water out of the cell. So rapid correction of the hyperglycemia without an appropriate increase in the serum sodium may decrease the serum osmolality, may cause brain edema, especially in young adult with the ketoacidosis. So pseudohyponatremia observed in presence of high triglyceridemia can be found in patients with pancreatitis and diabetic ketoacidosis. So this is the formula for calculating pseudohyponatremia, that is sodium plus glucose minus 100 upon 100 into 1.6. Or for every 100 mmHg of the glucose more than 100 mmHg, add 1.6 milliequivalent of the sodium. The volume of extracellular fluid may further divide hyponatremia as hypovolemic, euvolemic, or hypervolemic. So determining patient's volume status is often difficult but can be very helpful in defining the etiology of the fluid loss. Inadequately suppressed ADH may be found in hypovolemic patient and in patient with heart failure or cirrhosis that might be also due to edematous. It should be managed under continuous monitoring coupled with simultaneous intravenous furosemide administration or in order to promote water extraction via forced natriuresis. In addition, if case of acute hyponatremia is parenteral fluid administration in patient with the post-operatively induced syndrome of inappropriate antidiuretic hormone, large volume of isotonic saline will expand the ECF and worsen the cerebral edema. So one more component that is necessary for the diagnosis of hyponatremia is urinary sodium. If we know these three value, that is serum osmolality, volume status, and this urinary sodium, we can diagnose the etiology of hyponatremia. There is a formula for calculating serum osmolality, and it should be calculated like uh, 2 into sodium plus blood urea nitrogen upon 2.8 plus glucose upon 80. So if the serum osmolality is normal, then it is a pseudo hyponatremia, which is occurring because of the hypertriglyceridemia or hyperglobinemia. If serum osmolality is less, if serum osmolality is elevated, then it may be because of the causes like hyperglycemia or or excessive administration of the mannate. If serum osmolality is low, then that is a true hyponatremia. In that case, we need to administer the volume status. If it is hypovolemia and if the measured urinary sodium is more than 20, then this hyponatremia, so the reason for the hyponatremia is the renal losses which occurred because of the excess use of diuretic, mineralocorticoid deficiency, salt losing nephropathy, bicarbonatremia with renal tubular acidosis, and metabolic alkalosis, ketonuria, cerebral salt wasting syndrome. If measured sodium level is less than 20, then the extra renal losses are responsible, like vomiting, diarrhea, third spacing of the fluids in burns, pancreatitis, and trauma. If the volume status is euvolemic and the urinary sodium is more than 20, then the probable etiology is hypothyroid, drug-induced glucocorticoid deficiency, and SIDH. If patient is hypervolemic and the measured serum sodium is more than 20, then the probable etiology is acute or the chronic renal failure or pregnancy. If measured serum sodium is less than 20, then the probable etiology is nephrotic syndrome, cirrhosis, and heart. So the treatment rate of correction basically depends upon the severity of the symptom. The type of the fluid and the speed of administration are the cornerstone of the initial management and are calculated based on the equation for the sodium deficit. That is 140 minus serum sodium into total body water, where total body water is calculated as body weight into 0.6. In patient with the acute severe hyponatremia with symptom, the goal of serum sodium correction is uh, 4 to 6 mmol in first 6 hours or less, and should be maintained at the same level over the first 24-hour period to avoid development of osmotic demyelination syndrome. In any case, the rate of serum sodium correction should not exceed 8 mmol per liter in any subsequent 24-hour period. The underlying rationale for such a treatment is that 4 to 6 mmol per liter increase in serum sodium reverses the majority of symptom of hyponatremia, and the larger increase do not offer any therapeutic advantage. Conversely, osmotic demyelination syndrome has occurred most frequently in patients whose serum sodium was raised by more than 10 mmol within first 24 hours or more than 18 mmol within 48 hours. It is important to have hourly monitoring in the treatment of acutely developed severe hyponatremia with initial boluses of at least 100 ml of 3% saline that may be repeated after each sodium biochemical evaluation until therapeutic goal of 4 to 6 mmol increases serum sodium is reached. The frequency of monitoring may be decreased to 6 to 12 hours after desired increase in the serum sodium is achieved. Finally, despite all preventive measures to avoid overcorrection of hyponatremia, ODS may develop in patients with severe hyponatremia lasting for more than 2 to 3 days, and also possible with emergence of water diuresis. These patients need a rescue strategy for relowering of serum sodium with oral intake of water, administration of 5% glucose solution at the rate of 2 to 4 ml per kg per hour over 4 hours, and desmopressin in the dose of 1 to 3 microgram IV or subcutaneously at the interval of 8 to 12 hours concomitantly with subsequent sodium monitoring. The therapy may be repeated if serum sodium is not lowered by 1 mmol per liter per hour or until it falls within the therapeutic goal. Moreover, the corrective measure of hyponatremia should be stopped once lowering strategy is initiated. In severe symptomatic acute hyponatremia, rapid correction with 100 to 150 ml IV bolus or 2 to 4 ml per kg IV administration of 3% hypertonic saline solution in 20 to 40 minutes is either repeated based on the persistence of symptom or given until 5 mmol per liter of sodium increase over 1 to 4 hours is reached. Severe hyponatremia should be urgently treated with no consideration of type or etiology, but simultaneous measure of sodium correction in initial 24 hours should be vomited, as rapid hyponatremia correction may lead to complications. Loop diuretic may be administered in congestive heart failure patient, hydrocortisone in case of adrenal insufficiency, and potassium chloride in case of hypokalemia. Alternatively, continuous 3% hypertonic saline solution infusion may be administered at a dose of 0.5 to 1 ml per kg per hour. One of the few recent studies on severe hyponatremia due to SIADH prospectively investigated 50 patients treated with either hypertonic saline administered at slow continuous infusion at 20 ml per hour or at the rapid intermittent bolus of up to 200 ml bolus of 3% hypertonic saline. The primary outcome was overcorrection at any given point, defined as increase in the sodium level of more than 12 to 18 mmol per liter within 24 or 48 hours, respectively. The results showed that both rapid intermittent bolus and slow continuous infusion therapy with hypertonic saline for treatment of hyponatremia were effective and safe with no difference in need for overcorrection. However, rapid infusion of bolus had lower incidence of therapeutic relowering treatment and tended to have better efficacy in achieving desired serum sodium level within first hour uh, compared to the continuous infusion, slow continuous infusion. Overall, the results showed that rapid intermittent administration of hypertonic saline is preferred treatment of symptomatic hyponatremia, which is consistent with current consensus guidelines. Hence, it is recommended to use 3% hypertonic saline bolus at the dose of 100 to 150 ml, that is 2 to 4 ml per kg in 20 to 40 minutes, with repetition until desired sodium is reached, or as a continuous infusion strategy at a dose of 0.5 to 1 ml per kg per hour. Importantly, continuous infusion should be preferred in patient with hypokalemia, giving opportunity for administration of potassium chloride, that is 20 ml per 500 ml of 3% hypertonic saline. In this combined treatment of hyponatremia and hypokalemia, sodium monitoring every 2 hours is required because potassium supplementation lead to additional sodium efflux from the cell and possible rapid overcorrection, that is overshooting, with subsequent hypernatremia and risk of ODS. Importantly, an increased urine output may also be associated with greater increase in sodium and thus potential overcorrection. The question remains whether to treat severe chronic hyponatremia of less than 120 milliequivalent. Although there is no randomized controlled trial on such a treatment, a slow 3% hypertonic saline of 50 to 30 ml per hour administered intravenously, even in asymptomatic patient with regular follow-up to prevent ODS, would be used. In case of mild to moderate hyponatremia with symptom, a slow infusion of 3% NaCl should be administered after calculation of sodium deficit and frequently monitored. However, mild to moderate chronic hyponatremia is usually asymptomatic since central nervous system is gradually adapted to osmotic changes. Hence, evaluation of volume status in the etiological assessment of hyponatremia may be crucial for administering appropriate therapeutic measure. In addition, there are variety of pharmacological options for each particular type of hyponatremia, despite scarce evidence for firm recommendation of their practical use. In general, less aggressive treatment is certainly required in mild to moderate asymptomatic hyponatremia. If hypovolemic isotonic NaCl fluid without diuresis should be administered, and if euvolemic, it should be restricted to 1 liter of daily fluid. In hypervolemia, the underlying cause should be treated by restricting salt in the fluid, and diuretic should be regularly used. More frequently, mild to moderate hypovolemic hyponatremia may be viewed as consequences of a compensatory response of ADH to the loss of electrolyte and free water, either through gastrointestinal system in the form of diarrhea, vomiting, kidney, that is high doses of diuretic, tubulopathies, primary adrenal insufficiency, hypoaldosteronism, and bleeding. Hence, etiological treatment along with volume replacement is essential. Parenteral administration of physiological saline, that is 0.9%, at a dose of 23 to 30 ml per kg per day, is considered sufficient for sodium correction, but safe in terms of possible overcorrection. In case of stable patient with feasible oral intake of fluid, daily ingestion of 9 gram NaCl in the couple of small liquid portion and meal has been suggested. Regardless of route of administration, initial sodium monitoring after 6 to 8 hours and 24 hours is required in order to avoid overcorrection with appropriate treatment adaptation. Basically, mild to moderate hypervolemic hyponatremia may occur in patients with congestive heart failure or liver failure and nephrotic syndrome. The expansion of extracellular fluid and the low intravascular circulatory volume is common characteristic for all three conditions. A differential diagnosis of hyponatremia due to any other cause or continuous assessment of blood volume is crucial for appropriate treatment. The fluid restriction should be the first choice for the treatment in the congestive heart failure, liver failure, with recommendation for water intake only when thirsty and monitoring of the diuresis. Loop diuretic restrict the tubular permeability of electrolyte efflux and reduce the osmolality of the medulla with subsequent ADH stimulation. They are most effective for the treatment of hyper and euvolemic hyponatremia. Furosemide doses vary between 20 to 40 mg every 8 to 12 hours, being particularly effective with daily salt intake of 3 to 5 grams and in case of increased urine osmolality of more than 350 m osmol per kg. In the Everest study, tolvaptan was shown as safe and efficient drug with sodium increase of 5 to 6 mmol in 7 days in hypervolemic hyponatremia caused by CHF. Importantly, the initial dose of 15 mg leads to the slow and continuous increase in serum sodium without risk for overcorrection. Hence, monitoring sodium level is not required unless there is simultaneous use of lutein. Tolvaptan may exert possible adverse effect of hypertransaminemia and should not be used in liver failure unless needed before immediate preoperative transplant preparation. Albumin treatment is not justified except in the advanced liver disease with hypovolemia and low circulatory volume in order to increase oncotic pressure and extracellular volume, which in turn decrease the ADH stimulation. In this regard, the level should be maintained as close as possible to lower limit of normal. Although without firm evidence, it is believed that urea at the dose of 15 to 60 gram per day increases osmotic effect on proximal tubule and thus amount of diuresis, mainly in patients with the CHF. Additionally, it seems to be very effective and safe treatment for prevention of possibly associated morbidity and mortality. Osmotic diuresis increased by SGLT2 inhibitor may be useful as a last treatment option in heart failure patient as well, yet it is not evidence-based recommendation. Mild to moderate euvolemic hyponatremia is common type of hyponatremia in hospitalized patient, but also in outpatient. The most frequent causes SIDH. Other plausible etiological causes are hypothyroidism, hypercortisolism, elevated ADH, use of specific drug, paraneoplastic process, and it need to be evaluated before initial therapy for SIDH is commenced. Selection of treatment options should be based on clinical evaluation and risk benefit analysis since there is no best therapy that fits all SIDH patients. With fluid restriction, body fluid water elimination should be exceed the daily intake of water. Although recommended as first line option by European and American guidelines, For treatment of hyponatremia, the efficacy of fluid restriction is questionable. However, as evidence from the single RCT at present, only two-thirds of SIDH patients on fluid restriction compared with non-treatable patients reached that sodium goal of more than 130 after 3 days of treatment. The standard recommendation to drink only when thirsty or eating might to certain extent be efficient. Thus, that is, if strictly respected, it was shown in retrospective study of SIDH with chronic mild hyponatremia that such a restriction may be efficient in normalization of sodium in 76.5% of cases. Sodium correction is at very slow rate of 1 to 2 m equivalent per liter every 24 to 48 hours for only couple of days. In addition, fluid restriction may be more efficient in cases of preserved renal function that is usually reduced in the elderly. Fluid restriction is not recommended in malnourished patients and those with no compliance with need for IV fluid of more than 1 liter per day, especially during climate conditions with high temperature. Loop diuretics are efficient in the treatment of euvolemic hyponatremia, particularly when urine osmolality is more than 350, although the evidences is scarce. However, in recent RCT in 92 SIDH patients, the combination of furosemide, NaCl, and fluid restriction was not superior in correction of serum sodium compared with fluid restriction alone. In addition, the incidence of acute injury, acute kidney injury, and hypokalemia was increased in furosemide group. At present, though relatively expensive, Vaptans are the drug with the best existing evidence for sodium normalization in almost 48 hours. However, American and European guidelines did not reach the same conclusion regarding the medication use. In addition to the common use in SIDH patients, US guideline, unlike European guideline, recommended their use in patients with the cirrhosis or heart failure who fail to limit their fluid intake. The scarce evidence suggests that Vaptan may be slightly more effective than fluid restriction alone in hypervolemic and euvolemic hyponatremia, but should not be used in people with the hypo. Vaptan should be used cautiously by trained professionals in hyponatremia field with adequate hospital facility and possibility for immediate reaction in case of overcorrection. The initial Vaptan dose is 7.5 mg and should be carefully monitored if sodium increase of more than 5 mmol per liter in 6 hours. Dose may be doubled if correction of sodium is less than or equal to 8 mmol at 24 hours with same repetition after 48 hours. However, in specific patients with hypokalemia, alcoholism, malnutrition, liver disease, and or at high risk of ODS, sodium correction should be limited to 8 mmol per liter, and in average risk patient up to 10 mmol per liter and up to 12 mmol per liter for 24 hours in others. Serum sodium should be measured every 4 to 6 hours, and if increased has reached 8 mmol per liter in first 12 hours, measure to prevent further increase should be instituted by matching urine output with 5% dextrose in water. Overcorrection should be treated by bracking protocol with desmopressin administration 2 micrograms subcutaneously if sodium increase up to 5 mmol within first couple of hours. If between 6 and 8 mmol per liter, additional IV glucose of 5% should be administered at the dose of 2 to 3 mmol per kg per hour for 2 to 3 hours. If inadvertent overcorrection has occurred, there is window of opportunity to again decrease serum sodium level using desmopressin to prevent brain lesion. There is no evidence for use of urea as a single or combined treatment with Vaptan. The analysis of couple case series showed lower frequency of overcorrection and no cases of ODS associated with urea treatment. The initial dose is 15 gram and if sodium is corrected above the limit, next dose may be omitted. Conversely, if sodium correction is insufficient on third day, the dose should be doubled. The SGLT2 inhibitor empagliflozin is the effective treatment at the dose of 25 mg per day compared to placebo, with median sodium increase of 10 mmol per liter, although randomized studies are still out. SGLT2 inhibitor treatment is more efficient in case where intake of 1 to 2 gram of salt per meal and hypertonic NaCl in 500 ml of physiological solution is administered. In addition, potassium-rich food and IV potassium chloride infusion may be useful for parallel sodium increase. So this is the treatment algorithm for severe hyponatremia. If there is severe hyponatremia and serum sodium is less than 125, then administered hypertonic saline in the bolus of 10 to 120 ml over 20 to 40 minutes, or hypertonic saline in the continuous infusion form of zero point 0.5 to 1 ml per kg per hour. If sodium increases less than, if increase in sodium is less than 4, then we have to repeat the 3% hypertonic saline bolus over 20 to 40 minutes. If a rise in sodium is 4 to 6, stop. If sodium rises more than 6, stop and consider desmopressin 1 mg subcutaneous or IV every 8 hourly, and dextrose, that is 4 ml per kg, to decrease 1 mol per 1 mol of sodium. In case of mild to moderate hyponatremia, as I have mentioned already, we need to calculate osmolality and we need to know volume status of the patient, as well as serum, as well as urinary sodium. If the in case of hypovolemia, if urinary sodium is more than 30, then it is renal cause. If it is less than 30, then non-renal cause. In case of renal cause, discontinue diuretic, and if urinary potassium is low, consider fludrocortisone of 0.05 to zero point 0.2 mics per day. If urinary sodium is less than 30, then discontinue diuretics and antiemetics if needed, and causative treatment if possible. Then correct it with the volume supplementation, that is physiological saline 0.9% up to 30 ml per kg, and oral salt intake in meals, that is 9 gram per day. In case of euvolemia, the cause is SIDH. Also exclude thyroid, adrenal disease, drugs, infection, tumor, major plasma, and urinary sodium. Then, if it is SIDH, then go for the fluid restriction. If diuresis is less than 500 ml or serum sodium increases less than 2 in 24 hours, also we can take help of drugs like loop diuretics, tolvaptan 7.5 mg per day, and monitor serum sodium for overcorrection. Also, we can treat it with the urea 15 gram per day and SGLT2 inhibitor, that is 25 mg per day. Sodium intake 1 to 2 gram per meal, and potassium to rich food. In case of hypervolemia, if the sodium urinary sodium is more than 30, then it is a renal cause. Treat it with either fluid restriction in the form of loop diuretics, tolvaptan, and go for nephrologist if there is no response. If urinary sodium is less than 30, then it is a non-renal cause. It also, we have to treat it with the fluid restriction in the form of, or we can give diuretics like furosemide 20 to 40 mg every 8 to 12 hours, torsemide 2.5 to 10 mg every 12 to 24 hours, and salt, that is 3 to 5 gram per day. If serum sodium increases less than 2 ml per day, then tolvaptan 15 gram per day, and monitor sodium up to 24 hours. Administered urea, that is 15 to 60 gram per day. SGLT2 inhibitor 10 to 25 gram mg per day. So this is the various pharmacological option for the treatment of hyponatremia. So first is isotonic saline that we can administer in hypovolemic hyponatremia in the dose of 23 to 30 ml per kg. 3% hypertonic saline can also administered in severe hyponatremia in the dose of 2 to 4 ml per kg as bolus, or if we are planning to give it by continuous infusion, then 0.5 to 1 ml per kg per hour. We can also administer loop diuretic in the case of SIDH, hypervolemic hyponatremia. In case of diuretics, we can give in the form of furosemide and torsemide. Furosemide in the dose of 20 to 40 mg every 12 hours. Torsemide 2.5 to 10 gram every 24 hours. Also, we can administer Vaptan if diagnosis is SIDH and hypovolemic hyponatremia. Vaptan we can administer in the dose of tolvaptan, that is 7.5 to 60 mg. If the diagnosis is SIDH, we can also treat it with the urea in the dose of 15 to 60 gram and SGLT2 inhibitor in the dose of 10 to 25 mg. Thank you.